Hello and welcome to Arbor Rehabilitation's compliance training for 2020. My name is Cindy Hudson and I'm the Director of Clinical Compliance. Thank you for your time and attention today. Our agenda for this brief webinar is to touch base on PDPM related critical MDS sections, as well as CPT code selection reminders, documentation tips, some licensure updates, incident reporting, and compliance updates. We're going to start by talking about Section C for cognition on the MDS. We need to communicate any kind of cognitive findings to the MDS nurse for the most accurate scoring and reimbursement categorization. Speech therapy documentation should reflect BIMS scoring that's done upon the initial assessment. If no data is collected in the initial assessment by either nursing or speech or occupational therapy, cognitive impairments cannot be factored into the speech or nursing component for PDPM reimbursement. The BIMS is a standardized assessment and it's preferred over the staff assessment because the staff assessment is a compilation of patient-related observations, whereas the BIMS is again a standardized tool. Proper administration of the BIMS is essential for accurate outcomes and scoring. Reference your PDPM training materials for detailed information on administering the BIMS and locate that webinar on Arbor Rehabilitation's website under the employee portal, Everything PDPM in Nutshells. You'll be able to see that instructional webinar. Consider providing the BIMS for, I'll say, everybody on a speech caseload, including those with dysphagia, because doing that can justify why you might need a little bit of extra time to help them remember the strategies and techniques that you're training them on. It can help justify that length of service. So, quick question, are enteral feedings considered a mechanically altered diet for Section K? Well, in Section K on the MDS, this is going to look at relevant swallowing disorders and diet alterations that will impact patient classification under PDPM and the payment component for speech-language pathology. So Section K100 on the MDS is related to swallowing disorders, and it considers a minimum of 1 episode in the past 7 days as a swallowing disorder, and that includes 1 episode of either having a feeding tube or an altered diet, loss of liquids or solids from the mouth, holding or pocketing foods, choking or coughing during meals or medications, complaints of pain or difficulty with swallowing. Any one of those episodes in the past 7 days qualifies in Section K100. Section K510 on the MDS determines interventions, if applicable, while not a resident and while a resident within the past 7 days. So this is a look back into potentially their hospital stay. And that can include parenteral or IV feedings, feeding tubes, J-tubes, G-tubes, PEG tubes, mechanically altered diets, which indicate a change in texture of the food or liquid. And by the way, enteral feeding formulas are not a mechanically altered diet. And just as a distinction on terminology, a therapeutic diet would include diets that are, for example, low sodium or diabetic, whereas mechanically altered diet has that change in texture of the food or the liquid. Just so we have our terms straight about therapeutic versus mechanically altered. A little bit more on Section K, a thorough chart review is going to be very important, and communicate your findings with the MDS because we want to make sure we get the best information to them for the most accurate PDPM scoring, the case mix group scoring. So swallowing difficulty may include coughing during a trial of upgraded texture or consistency, or a patient report of difficulty if they feel the food is getting stuck. Some IV fluids in the past 7 days will count in Section K, which includes while they're at the hospital. We don't need to necessarily know what each of those fluids are, but if we see something in the chart, we want to make sure the MDS nurse is aware as well. The issue or incident only needs to happen once, and it can include difficulty swallowing medications. So we want to make sure that we're sensitive to all of these things that can trigger a shift in the case mix grouping. Again, see something, say something. So another quick question, why is it important for evaluating therapists from all disciplines to carefully review the chart for all of the patient's ICD-10 diagnostic codes? Why do the evaluating therapists need to be very scrutinous of ICD-10 codes? We're going to talk about Section I next, which includes ICD-10 coding information. Proper coding helps to drive reimbursement, the case mix score, by getting our patients into the most appropriate clinical category. So unspecified codes, if the ICD-10 code description includes the word unspecified, if we see that, we should prompt a discussion among the administrative teams because those codes can often result in no reimbursement. If we find those codes and discuss it, the MDS nurse has a chance to pursue whatever better coding might be appropriate. And you as therapists, clinicians at Arbor, you've been well trained in thorough chart review. This has been going on since before PDPM, certainly as we prepared for PDPM. We know that we have to very carefully scour the charts for all relevant information. And oftentimes we might be the ones to spot something that our nursing counterparts might have overlooked. When we see something, we need to communicate this information. Section I on the MDS has a fill-in section that can assist with capturing speech-related comorbidities. So again, if anything that we see, make sure we communicate. The primary diagnosis for the SNF admission, which is captured in section I-20B, is going to drive the primary clinical category for speech, OT, and PT case mix grouping. And those ICD-10 codes cannot result in a return to provider code or an RTP code. When you're looking at the chart, be on the lookout for major diagnoses that are not on the face sheet. Look for recent surgeries within the past 100 days, and those diagnoses that can constitute or contribute towards speech comorbidities. Make sure to include all ortho or neuro-related diagnoses on that top ICD-10 listing in the body of your evaluation, but maybe try to limit that to about the top 5 key diagnoses so that they really stand out as the issues that are contributing to why this person is as complicated as they may be. Touching base on section GG, and I know we've gone through a lot with this, we need to make sure that we support section GG data in our documentation. Evaluations and discharge summaries should reflect GG scoring. Break down the components in your functional assessment when you can. For example, looking at bed mobility with rolling separated out from supine to sit to supine. Remember to include in your scoring your documentation for car transfers, stair climbing, picking up objects from the floor, putting on and taking off socks and shoes. Make sure we've got documentation to support GG scoring with those areas. Provide detailed information in your treatment encounter note about GG specific items only if there are goal-related items to be documented upon. Use the GG crosswalk when you're scoring to make sure that you're being accurate with how we're translating MDS terminology from therapy terminology. Dashing is an exception and should not be seen regularly for GG items, and our clinicians are only required to provide one goal for self-care and one goal for mobility. You don't need to provide goals for all of those areas. This is our section GG crosswalk. It's on our website on the employee portal. Again, under everything PDPM, you can find this translator, so to speak. Some additional compliance areas, moving on from the MDS a little bit. CPT coding accuracy. Clinicians are responsible to thoroughly understand what and how to bill. It's your license associated with that bill. You need to be very clear and accurate with what you're doing with the billing. Billing of CPT codes must reflect actual time of service delivered, not rounded or estimated time. So when we see a bunch of billing that ends in the number 5 or 0, we know there's likely a lot of rounding going on. You need to reflect the actual time of service delivery. For physical therapy, gait training, or code 97116, it is anticipated that this service is billed for at least 15% of all delivered PT services within a 30-day look back. So when we look at a whole physical therapy department, we look at their use of billing codes, at least 15% of those codes should be towards gait training. With the occupational therapy, the same is true for self-care training, with the difference that we anticipate that this service is billed for at least 22% of all delivered OT services in a 30-day look back. We want to be focusing on function. Looking at the utilization of these codes helps us to know where each department is in that in relationship to that. Intensity of billing code recommendations per CGS, which is our insurance intermediary for the state of Ohio, but a lot of other insurance companies will follow suit. And if you feel you need excessive sessions from what's noted below here to maximize patient safety, let me know. We need to discuss how we need to carefully document this. So manual therapy is expected to be at about 18 visits per CGS. We should be providing about 12 visits of a modality, 6 to 8 visits for massage, wheelchair management and training 4 visits. And I realize this is one where we frequently want to exceed that threshold. Talk to me about how we need to carefully document for this. Orthotic training, again, this is one we may want to go over 3 visits. We need to discuss careful documentation, as well as with orthotic and prosthetic checkout. That is for about 2 visits per our intermediary. So some coding information can be found on our employee portal. Again, we have information for New hire training, the tab for new hire training has information about the OT and PT evaluation codes. And if you look under everything PDPM in nutshells, there's information about GG scoring and some CPT coding tips under the In a Nutshell tab. So documentation to support medical necessity. The need for this has not gone away with PDPM by no means. We need to have thoroughly documented prior level of function and baseline status for all goal-related areas. We need to write SMART goals, which are specific, measurable, achievable, realistic, and time-based goals. We need to have the frequency and duration that is appropriate for the impairments that we've noted and the outcomes or goals that we've defined. We need to do standardized tests and measurements to help document functional progress, to document evidence-based objective information. And you've heard me say this multiple times before, but it's still very important. We need to provide thorough documentation of functional impairments and the barriers to treatment. Those barriers can help justify why we have ongoing therapy. We need to use skilled terminology. We need to define what is taking the sophistication of a therapist. And under the employee portal, we have some tips and techniques for that. We want to be careful to include patient response to our teaching and training. Real important to note the caregiver response to our training, because if we don't document that they have partial understanding, thorough understanding, we are leaving ourselves open liability-wise to any kind of issues that might arise if something goes wrong when the caregiver is providing that care. So on our employee portal, again, under CEU 360 and documentation tab, clicking on documentation training opens up a variety of tip sheets, and we have the skill documentation phrases, which is then what's shown here on the screen with the In a Nutshell, where there's some tips and strategies and some phrases you might want to consider using to define what took your sophistication for various treatment areas that we provide. Moving on to licensure updates. Ohio Physical Therapy continuation requirements are changing. The jurisprudence module, or JAM, will be required for renewals beginning in 2022. So be sure to check out the Ohio Physical Therapy Board website for updates with that. Student affiliations and rotations, when they can happen again someday. Again, this is the summer of COVID, so we don't know when that might be a possibility again. But when you are considering a student, make sure you've discussed it with your area manager or your director of clinical ops, DCO, prior to agreeing to or accepting a student. Both the clinical instructor and the students are responsible for understanding the guidelines for the delivery of service in a skilled nursing environment. All necessary arbor rehabilitation paperwork needs to be completed and submitted prior to the end of the first day of that student affiliation, and that information can be submitted by fax or by email to the corporate office. It also needs to go to your area manager or director of clinical operations, as well as to the director of clinical compliance, which would be myself. That document needs to include the HIPAA guidelines, the confidentiality agreement, and the resident abuse agreement. If you need those forms, they're found on our website, employee portal, under forms. The electronic student documentation is to be done in the sandbox only. Students are not to be documenting on actual patients in Rehab Optima. So another quick question. Upon entering a patient's room to start therapy, you find them on the floor beside their bed. The person simply states that they slid off the side of the bed and they have no pain or injuries. So would this be an incident report? Would you need to do an incident report? And the answer to that is yes, because an incident is reported as anything that's not part of the usual or routine patient care. And finding somebody on the floor is definitely not part of their routine care. It's recommended that incident reports are completed immediately after an incident when it is safe to do so. That incident report needs to get submitted to the FRC to share with the facility, the Arbor corporate office. It needs to go to the area manager and the director of clinical operations, as well as to the director of clinical compliance. The incident report needs to include a detailed and descriptive account of the incident in objective terms. So we need to have the time and the date and location of the incident. We need to know who's been involved. We need the details on how and what happened with that incident. Any visible or verbally reported injuries, such as bruises or cuts, complaints of pain. And we need to carefully note any kind of equipment, safety equipment or whatever might have been in use at the time of the incident. Excuse me, touching base on compliance. The role of the compliance individual is to provide audits and to ensure that we are adhering to regulatory guidelines. We need to be providing education. We need to provide investigations of any concerns that might arise. Ways to report a compliance concern can be through notifying your FRC, You can talk to your area manager or the director of clinical operations. You can notify the corporate office, and you can notify through the website. We have an anonymous reporting option through our portal. You can describe as much information as you're comfortable with. That information comes to myself anonymously if you choose, and we can investigate as able from there. So the very last tab in the left-hand column of the employee portal has a section for compliance alert. When you click on that, that opens up an option to complete a form, and you see portions of that form here. Again, as much information as you can provide enables me to do the best investigation as possible. If you see something that's a concern, please say something. We can't fix a problem if we don't know it exists. So some final thoughts. Resident rights, they still do have rights, even though COVID has hampered, it would appear to be many of them. But the important thing to note is that residents have the right to have their door knocked upon before somebody enters the room. And I know a lot of doors are closed these days. But knocking isn't just a courtesy, it is actually a requirement to respect residents' rights. Be sure you're knocking. With infection control, nursing home residents account for over 70% of the COVID-related deaths in Ohio as of June 2020. Therefore, state surveyors are going to be looking for strict adherence to infection control procedures. And so we need to be sure that we are not at fault for any violations of infection control. We thank you very much at this time for your dedication, your compassionate and creative care of people. We know there's a lot of unusual things occurring at this time, atypical treatment sessions that have now become kind of typical. Thank you for your compassionate care. If you need to contact us, my name and contact information is there, as well as Mark Stapleton, our Director of Clinical Operations. Have a great day ahead. Again, thank you for your attention.